Hello, my name is Elif. I make anatomy and medicine videos. If you like my videos, please subscribe my YouTube channel and follow me on my Instagram and Facebook pages.
Hello! In this video, I will talk about layers of the heart, its embryologic development, anatomy, histology and pathologies of pericardium such as cardiac tamponade. The heart has multi-layer lining. It has three layers from outside to inside. Pericardium, or if we talk about attached to outer layer, we have to say epicardium layer of pericardium, myocardium and endocardium. In order to better understand layers of the heart, it is necessary to learn how the heart transforms from a simple tubular structure to a four-chambered organ that can maintain its own independent circulation at birth. The development of the heart, also known as cardiogenesis, begins when two endocardial tubes fuse to form the tubular heart in an area called as cardiogenic region. The cardiac primordium appears on the 18th day. In the figure, we look at the state of an embryo on the 18th day. The embryo has a head, which is a cranial part, and a tail, which is a caudal part. The heart begins to develop in the cardiogenic region, near the cranial part of the embryo. Please note that cardiogenic region is an area that derived from splachno-pleuric mesoderm. When we take section of the 18th day cardiac primordium from the level in the figure, we see the following structures: splachnic mesoderm, pericardial sulum, angioblastic cords, embryonic ectoderm, embryonic endoderm, and yolk sac. The splachnic mesenchymal cells, ventral to the pericardial sulum in the cardiogenic area, aggregate and form two angioblastic cords. These cords then form a lumen and canalize to form two endocardial tubes after day 20. In the meantime, the tubes form the main components of the heart. On the day 21, both endocardial tubes converge and merge to form a single endocardial tube. This union takes place from cranial to caudal. To get into a little more detail, let's take a transverse section on the 20-day embryo. In a transverse section taken from the level shown, there are endocardial tubes, pericardial sulum, it will form pericardial cavity later, endoderm, mesenchyme, neural fold, neural groove, amnion, wall of yolk sac. This is formed by endoderm and extraembryonic mesoderm. Let's look at the coronal section when the ventral wall is removed on 20 day. The primordial myocardium will form the myocardium, the muscular middle layer of the heart. During the formation of primordial myocardium, the heart is a thin endothelial tube. This endothelial tube is separated from primordium myocardiale by a gelatinous connective tissue. Primordium myocardiale is a thick muscular tube at that moment. Between endothelial tube and primordium pericardium, there is a connective tissue that known as the cardiac gel. The endothelial tube then form the endocardium, the innermost layer of the heart, from the mesothelial cells that originate from the other side of sinus venosus and they are distributed over the myocardium, will differentiate into the epicardium or visceral epicard. Now on the 18th day, the endocardial tubes, which are the in form of the two tubes, differentiate on the 20th day and begin to merge on the 21st day. And on the 22nd day, its merge will complete. And on the 23rd day, the heart is now in the form of a single endocardial tube. Remember the embryo on the 18th day. Just anterior to central part of the cardiogenic zone, there is oropharyngeal membrane. As the growth of the brain and cephalic folds push the oropharyngeal membrane forward, the heart and pericardial cavity are pushed to the cervical region, then to the chest. The heart tube forms the truncus arteriosus, bulbus cordis, primitive ventricle, primitive atrium, and sinus venosus. As the cranial portion of the embryo folds, the heart tube extends and bends into the pericardial cavity. Bulbus cordis and ventricles grow faster than the other regions. Therefore, the heart folds back on itself approximately on day 28 and forms the U-shaped bulboventricular fold. It is also known as ansa bulboventricularis in Latin. Initially, the heart first hangs by the dorsal mesocardium, suspended from the posterior wall, but then the middle part of the mesentery degenerates and a connection is formed between the right and left edges of the pericardial cavity. This connection is the transverse pericardial sinus. After that, the heart is only hanged at its cranial and caudal parts. Let's take lateral views of the embryonic heart and some of its stages of development. Here is the arterial ends and venous ends of pericardium inside the pericardial sac. The primordial heart tube starts to invaginates double-layered pericardial sac. Primordial heart tube creates a U-shaped form ventrally and brings primordial arterial and venous ends together. This creates primordial transverse sinus between them. Bulbus cordis and ventricus grow faster than other regions, therefore the heart falls back on itself and forms a U-shaped bulboventricular fold. In later stages, following structures as it seems in the figure: pulmonary trunk, visceral pericardium, parietal pericardium, pericardial cavity between visceral and parietal pericardium. Later stages of the embryo, the veins expands and separates into branches inferiorly and laterally. The pericardium reflects around these veins, forms the boundaries of the oblique pericardial sinus. In the end, around pulmonary veins, the transverse pericardial sinus is located posteriorly to the aorta and the pulmonary trunk. Heart has 3 layers. Besides that, heart is also surrounded externally by 2-layered bag-shaped sac called the pericardium. It covers around the heart and roots of the great vessels. Pericardium is located between 2nd to 6th costal cartilage ribs. It prevents the heart from suddenly enlarging. It has 2 layers. The other thick and tough layer is fibrous pericardium or pericardium fibrosum in Latin, and the inner layer is serous pericardium. It is also known as pericardium serosum in Latin. Serous pericardium also has 2 layers. These are parietal layer, it is also known as lamina parietalis in Latin, lamina means layer, and visceral layer, which is lamina visceralis in Latin. This is also known as epicardium. The parietal layer of serous pericardium is located outside, which is more externally and adheres to the fibrous pericardium, while the visceral layer of the fibrous pericardium, it is also known as epicardium, is firmly attached to the heart. Potential space between parietal and visceral layer of the serous pericardium is pericardial cavity. It is also known as cavitas pericardialis in Latin. Cavitas means cavity in Latin. Ventrally, the visceral layer, or epicardium, folds back onto the upper surface of the heart and forms the parietal layer. Parietal layer is continuous with the visceral layer of serous pericardium around the roots of the great vessels. These reflections has been seen in 2 places. One of them of these places located more superiorly where the aorta and pulmonary trunks rounded. Other one is located posteriorly and surface of atria. Pericardium folds over epicardium and forms a vertical and horizontal fold. Visceral and parietal layer of serous pericardium forms transverse and oblique pericardial sinuses, as you can remember when we have talked about in the development of the heart. The transverse pericardial sinus, or sinus transversus pericardii, or thial canal, is located posteriorly to the aorta and the pulmonary trunk. This sinus can be found as inserting index finger posteriorly to the ascending aorta and the pulmonary trunk. Posterior to the finger, there is also superior vena cava. The transverse pericardial sinus is clinically important for cardiothoracic surgeons. After the pericardium is opened anteriorly, index finger passing through the transverse pericardial sinus, posterior to the ascending aorta and the pulmonary trunk, will separate arteries from veins. The oblique pericardial sinus, or sinus obliquus pericardii, or Heller's end, is a J-shaped blind-ending cul-de-sac bounded by pericardial reflections. It is located posteriorly to the left atrium, between the inferior vena cava and right pulmonary veins on the right side, and left pulmonary veins on the left side. This recess is shown when the apex of the heart is raised by inserting 2 fingers there. Fibrous pericardium is attached with the centrum tendineum of the diaphragm. From posterior side of the sternum, there are ligamenti sternopericardiaca or sternopericardiac ligaments. These are superior sternopericardiac ligament and inferior sternopericardiac ligament. Also, ligamentum vertebropericardiacum or vertebropericardiac ligament, ligamentum visceropericardiacum or visceropericardiac ligament, and bronchopericardiac membrane or membrana bronchopericardiaca. These connections are significant for to protect heart's normal position with surrounding structures and heart chambers exceeding their normal volume, especially right atrium and right ventricle. These connections also primarily protect the heart against injuries. Externally, mediastinal part of parietal pleura covers by the pericardium. Between pleura and parietal pericardium, there are phrenic nerves, pericardiophrenik arteries, musculophrenic arteries, coronary arteries, some branches of thoracic aorta. These are rami bronchialis, rami means branches in Latin, rami esophagealis, and rami phrenica superioris. Arterial blood supply of the pericardium is mainly provided by a branch of internal thoracic artery. In clinic, you can also hear this artery as internal mammary artery or IMA. Pericardiophrenik artery. This artery is generally accompanied phrenic nerve to the diaphragm. Minority portion of blood supply provided by musculophrenic artery. This artery is terminal branch of internal thoracic artery. Bronchial, esophageal, and superior phrenic arteries also are the branches of thoracic aorta. Blood supply of coronary arteries supply blood only to the visceral layer of serous pericardium. The venous drainage of the pericardium is accomplished from pericardiophrenik veins, tributaries of the brachiocephalic veins or internal thoracic veins. In the figure, we are looking at the right brachiocephalic vein and left brachiocephalic vein. Variable tributaries of the azygous venous system, which is also tributaries is brachiocephalic veins, and provide venous drainage of the pericardium. Azygous venous system is located bilaterally to the vertebral column and drains organs within the mediastinum, posterior, and thoracoabdominal wall. It consists of azygous vein and its tributaries, which is hemiazygous vein and accessory hemiazygous vein. To sum up, the venous drainage of the pericardium is accomplished from pericardiophrenik veins, azygous venous system, which is tributaries of brachiocephalic veins. The pericardium is innervated by the branches of the vagus nerve, which is the 10th cranial nerve, the phrenic nerve, and sympathetic nerve fibers. These fibers follow the route of the related blood vessels. Primary source of sensory innervation of the pericardium is carried by phrenic nerves. Phrenic nerves originates from C3, C4, and C5. Because of sensory branches that course with related phrenic nerve, the pain related with pericardium may be referred to the shoulder or supraclavicular region. To better understanding, let's take a look at the organization of skin. The skin consists of 3 separate layers, each with a different texture. These layers from surface to the deep are epidermis, dermis, and subcutis. In the figure, we see the epidermis on superficial to the skin. Under epidermis, there is dermis. In the dermis, there are intercellular support tissue and fibroblast cells, and nerves, vessels, lymphatic structures, sweat and sebaceous glands, nail and hair follicles are located among them. There are also receptors with sensory nerves in the dermis. Pain sensation in the skin is carried by pain receptors in here. Pain receptors are also called as free nerve endings. These simple receptors are found in the dermis around the base of the hair follicles and close to the epidermis where the hair emerges from the skin. Here is the cross-section of spinal cord. We are seeing spinal ganglion, which consists of bipolar neurons. Following structure is dorsal root of spinal cord. Afferent fibers, which carries impulses from dorsal root, carries impulses to the gray matter of spinal cord. Gray matter of spinal cord resembles a butterfly or letter-H shape and consists of soma, in other words, cell bodies of neurons. Because of cell bodies of neurons has darker shade than their axons, this area is relatively darker than its external area. External area is wider because there are axons of these cell bodies. Another structure in this area is posterior horn of gray matter. Afferent fibers carries the impulses to enter here. Basically, impulses from sensory nerve endings carries by a longer axon of the neuron in the spinal ganglion. It enters to the posterior horn of spinal cord and synapses related neurons in there. And then impulses sent to the thalamus and then the neocortex, specifically primary somatosensory cortex. Referred pain is a phenomenon used to describe pain perceived at the site adjacent to or at a distance from the site of an injury's origin. There are several proposed mechanisms for referred pain. These are the convergent projection theory, the convergent facilitation theory, the axon reflex theory, the hyperexcitability theory, and the thalamic convergence theory. But currently there is no definitive consensus regarding which theory may be correct. I will discuss these theories with more detail in another video. Neuronal mechanism and pathways of cardiac pain are still unclear. This is assumed cardiac pain, in other words, angina pectoris, may be a result of ischemic episode-induced chemosensitive and mechanosensitive receptors of the heart. Stimulated receptors cause the release of adenosine, bradykinin, and other substances. These events result in excitation of the sensory ends of sympathetic and vagal afferent fibers. The afferent fibers cross a bunch of nerves that occur connection of upper 5 thoracic sympathetic ganglia and the upper 5 distal thoracic roots of the spinal cord. Spinal cord transmitted impulses to the thalamus and then to neocortex. Inside spinal cord, cardiac sympathetic afferent impulses may come together with impulses from somatic thoracic structures. This is basis of the mechanism that heart pain referred to the chest. Potential space between parietal and visceral layer of serous pericardium is pericardial cavity, or cavitas pericardialis in Latin. Cavitas means cavity. This cavity contains a thin serous fluid which helps to reduce friction while the heart moves, so heart can move by sliding within pericardial sac. Serous fluid between layers of serous pericardium is pericardial fluid, or liquor pericardial. Liquor means fluid. Changes that affect volume of pericardial fluid can be lethal, so it is very important clinically and preferred subject that is frequently questioning in medical exams. Amount of the pericardial fluid varies between approximately 20 to 50 milliliters. Even solid liquid allows the heart move freely during systole or diastole. In cases such as pericarditis, the volume of this fluid can increase to a level like 10 times. Cardiac movements become difficult, and cardiac tamponade may develop as a result of increased fluid pressure on the heart. Cardiac tamponade is a result of an accumulation of pericardial fluid or bleeding in the pericardial cavity. Bleeding is related most commonly by aortic aneurysm. Also, ruptured myocardial infarct or penetrating injury may result with cardiac tamponade. If pericardial fluid is rapidly accumulates and reach greater volumes than its normal range, it will be resulted in cardiac tamponade. For example, even as little as 150 milliliters can result in cardiac tamponade. With the excessive accumulation of the fluid, right atrium will be compressed, and it will be result decreased venous return and loss of number of the heartbeats per minute. In other words, it will result with loss of cardiac output. Excessive accumulation of pericardial fluid requires immediate drainage surgically or by a procedure that known as Pericardiocentesis under echocardiographic guidance that avoids the breach of the pleura. Pericardiocentesis is a procedure to drain excessive fluid inside the pericardial cavity under the ultrasound guidance. These procedures' mortality risk is less than 1%. Also, with mortality rate of 1 to 3%, pericardiocentesis may be considered as a safe procedure. There are different approaches during entering the pericardial cavity for this procedure: parasternal, apical, and subcuspid. Complications will be different depending on the preferred approach. While apical approach has a risk of ventricular fibrillation, parasternal approach is related with higher incidence of pneumothorax. Although subcuspid approach is considered as the safest during an emergency, it may result in colonic, hepatic, and gastric injuries. Pericardiocentesis is done with using a needle and small catheter. During the procedure, the physician inserts the needle from the chest wall into the relevant layers of the heart. As soon as the needle enters into the pericardium, a catheter is inserted to drain excess fluid. This allows excess fluid to be drained before the catheter is removed. This process can take few hours, or it can last all night. The reason for the elongation of the pericardiocentesis is to ensure that all fluid is drained and prevent the cardiac filling. More chronic effusions can be under control by pericardial window creation using video-assisted thoracoscopic surgery, which is WATS. Treatment will be changed depending on the cause and the clinical findings. Epicardium. The epicardium is the outer layer of the heart consisting of the visceral layer of serous pericardium and the thin subserous connective tissue, mesothelium. Epicardium is attached to the heart muscle that contains collagen fibers and smooth muscle fibers. These collagen fibers surround the heart like a net, and while they are wavy during heart systole, they flatten during diastole, so limiting the expansion of the heart. The small amount of the elastic fibers also helps to restore the heart. The heart consists of special muscle, the heart muscle in the middle layer called as myocardium. This layer, which surrounds the heart with a complex structure, consists of bands. Its innervation is provided by autonomic nervous system like smooth muscle, but it has banded, striated structure like skeletal muscle. Therefore, the myocardium is similar in structure, partly striated and partly non-striated muscle fibers. Since the heart skeleton is in between, the muscle fibers surrounding the atrium and ventricles are not a continuation of each other. Thus, the atrium and ventricles can work separately. They can work independently of each other. The muscle fibers surrounding the right and left atria are not a continuation of each other. However, the muscle fibers that surround the ventricles are a continuation of each other. Therefore, cardiac muscle fibers are examined in three groups: fibers surrounding the atriums, fibers surrounding the ventricles, and atrioventricular fascicles, which is speed beam. The muscle layer surrounding the ventricles is thicker than the muscle layer surrounding the atria. While the layer surrounding the atriums is 2-layered, the layer surrounding the ventricles is 3-layered. The left ventricular wall, which can pump blood throughout the body, is 2 or 3 times thicker than the muscle fiber layer in the right ventricle wall. In the right ventricle, the myocardium is 3-layered. The difference in thickness of the walls of the right and left ventricles is associated with the difference in the systemic and pulmonary pressure. The blood pressure in the systemic circulation is about 5 to 6 times higher than the pressure in the pulmonary circulation. Similar to skeletal muscle, cardiac muscle expands when it contracts too much. The reason for this expansion is not proliferation of the muscles, but the lengthening and thickening of each fiber. Endocardium. The endocardium is a thin and shiny layer that surrounds the inner part of the heart cavities and chordotendinea, trabecular cornea, papillary muscles, pectinate muscles, combines with the own tissues of the vessels entering and leaving the heart. Endocardium consists of endothelium, stratum subendothelial, and stratum myoelasticum layers. The endocardium is connected to the myocardium by a loose connective tissue called the thallus subendocardialis, which contains blood vessels, nerves, and cardiac conduction system elements.